I'm taking Xanax, and from what I read in the papers, I'm reluctant to take them.
I take Vasotex. I'm supposed to take 1 gram, whatever it is, but I cut it in half because I figured it bothers me too much.
There is no question that there is a drug problem in the U.S. today, but there is another, less obvious crisis: medication problems caused by a lack of communication between health professionals and their elderly patients. Studies have shown that the average number of medications persons over the age of 65 are taking average between 6 and 7. Many are on considerably more. According to one survey, 40% of patients reported they were not told how to take their prescription medications. Nearly 70% state no one told them about precautions or side effects, and 96% said they did not ask questions about the drugs. In addition, older patients may be cognitively impaired, not only through the natural aging process, but oftentimes because of the adverse effects of prescribed medications, over-the-counter preparations, and herbal remedies. Multiple physicians, multiple pharmacies, an endless barrage of commercials, and the well-meaning advice of friends and family members further compound the problem.
Okay, Ms. Bryson, let's do your medication regimen. Are you ready for that?
Sure.
In-home health care, agencies participating in Medicare are required by the Medicare Conditions of Participation to complete a comprehensive assessment on every patient. According to Standard 484.55c, that comprehensive assessment must include a drug regimen review. The review must include prescribed drugs, over-the-counter drugs, and herbal remedies. This standard states that the comprehensive assessment must include a review of all medications the patient is currently using in order to identify any potential adverse effects and drug reactions, including ineffective drug therapy, significant side effects, significant drug interactions, duplicate drug therapy, and non-compliance with drug therapy. This requirement applies to all patients receiving care by the home health agency and focuses the assessment toward information predictive of a significant patient outcome. Home health agencies participating in the Medicare program are also required to complete the Outcome Assessment and Information Set, OASIS, as part of the comprehensive assessment on all adult non-maternity patients over the age of 18 who receive skilled home health services under the Medicare/Medicaid programs. Under the OASIS assessment requirements, the clinician conducting the assessment may be a registered professional nurse or a therapist, physical therapist or PT, speech-language pathologist or SLP, or occupational therapist or OT, depending on the services ordered and the time frame of the assessment. Thus, the need to understand how to conduct a medication history and drug regimen review is critical to all disciplines. Medicare regulations require that an RN make the initial evaluation visit and complete the comprehensive assessment, including the drug regimen review in all cases except when the physician has ordered only therapy services. However, when therapy is the only ordered service, physical therapists and speech-language pathologists may complete the start of care OASIS and drug regimen review. Occupational therapy can complete the start of care OASIS and drug regimen review for some payers. If OT is the only service required for continued care, then OT can complete the subsequent OASIS comprehensive assessments, and a drug regimen review would be necessary as well. Other accrediting bodies may have additional standards. For example, the Joint Commission on Accreditation of Healthcare Organizations has a medication management chapter with an increased focus on patient safety that includes both home health and hospice. Standard MM.5.20, applicable to hospice, addresses medications that are self-administered to assure that medications are administered safely and accurately, and that the person administering them is deemed competent. Patient education is required to be provided on the nature of the medication, how to administer it, expected actions and side effects, and how to monitor the effects of the medications. The various national therapy associations support the involvement of physical therapists, speech and language pathologists, and occupational therapists in identifying a patient's multidisciplinary needs and making interdisciplinary referrals as needed. It is the responsibility of each therapy provider to work within their own scope of practice and to limit themselves to those activities to which he or she possesses adequate training and experience to demonstrate competency. Medication use by patients can have an impact on their outcome with each discipline's plan of care. Medications can cause sedation, can alleviate or interfere with pain, and may improve or decrease functional ability. Some medications require monitoring be done prior to the start of a procedure or therapy regimen. Because many of the elderly are at high risk for falls, clinicians need to reinforce with patients the effects that medications can have, emphasizing safety factors to prevent falls. Notification of the patient's physician when meds are causing a fall risk is especially important in these instances. Thus, it is important that all clinicians understand the drug regimen review, how to take a medication history, identify potential adverse effects and drug reactions, understand basic pharmacology, and be knowledgeable about when to refer the patient for additional medical or other follow-up related to the patient's care needs. Whenever possible, before visiting the patient, the clinician should review the prescribed medication list. This information may be obtained from the physician, from hospital discharge orders, or even a recent or current CMS 485 plan of care. When reviewing these lists, note any stated allergies and potential drug interactions. Also consider what diagnoses correlate with the listed medications. If an appropriate diagnosis is not included in the initial service information, this may be an area to clarify with the physician. When calling to arrange the visit, ask the patient or family to gather all medications the patient is taking, including over-the-counter and herbal remedies, and to have them available for the visit. The following commentary, here and in the final section of the video on medication history and other aspects of medication use by the elderly, was recorded at the UCLA Medical Center. At the time of the taping, Dr. Mark Beers, creator of the Beers List, Drugs Considered Problematic for the Elderly, was assistant professor of geriatric medicine at the UCLA Medical Center. Sue Mendelson, RN, was the gerontological nursing coordinator at the UCLA School of Nursing, and Irene Tamai, doctor of pharmacology, was a clinical specialist in geriatrics at the Veterans Administration Medical Center in Sepulveda, California.
One has to keep in mind to get the history really from the person who's using the medications or the person who's giving out the medications. Often what the label on the bottle says bears no resemblance to what the person is actually putting in their mouth. People take considerably less than the bottle says, they take considerably more, and sometimes what's in the bottle isn't what the label says is in the bottle.
This medication history is taken from a reliable historian. However, when dementia is a factor, a similar history must be obtained from other sources, such as primary caregivers and family.
Today I want to go over your medications with you, and more or less take a medication history.
That's all right.
It's important to do this periodically so that we know that you understand about your medications, how to take them, and any adverse side effects that you might be having. Usually I start with your prescribed medications first, and then we'll talk about any over-the-counter medications you take.
Surely.
And any social drugs such as alcohol, tobacco, or caffeine. So let's start with your prescribed medications.
Yes.
You're on quite a few, I see. And I know you know the names of them because you told me earlier. And you have a nice list of them here. Do you know what you're currently taking them for?
I'm pretty sure I do.
Okay.
I can tell you if I have to.
Okay, I know you have a history of hypertension, and you're on several hypertension drugs. Are these all from one prescriber or one person?
Yes, I purchased them all in the same pharmacy, and they are all have been prescribed by my doctor.
Okay. And you're taking them as they're prescribed?
Yes, I do.
Okay. And because some people will take a medication and feel a little better, especially someone who has hypertension. They'll feel a little better, their blood pressure comes down, and they stop taking them. and they don't realize that perhaps they might have to take this medication for the rest of their life.
Sometimes I wish the doctor would tell you that, to take it continually without any interruption, or to take it only until you feel better. I think the doctor should suggest that, unless it's up to the patient to ask.
Right, and that's very important for you when you visit your doctor to go over these medications, just like we're doing today, to see if perhaps sometimes dosages can be reduced a little bit, sometimes medications can be tapered and discontinued, but that's entirely up to your reaction to these medications. Do you ever have any side effects or adverse effects of any of these medicines?
I did with the isosorbide.
Okay,
which is,
that's what I have in my hand right now.
which is similar to nitroglycerin.
Right.
I was taking the patch type of nitro, and then it was a reaction, skin reaction to that. So the doctor took it off and suggested this.
Okay, so this is isosorbide.
That's isosorbide.
And you're taking 40 milligrams. How are you taking those?
I take one a day. However, because of the reaction to it, I cut it and take a half in the morning and half at bedtime.
So you also had a reaction to the pill? Is that why you are splitting the tablets?
Yes, it was a type of reaction where it was very strong, and it gave me a terrific headache at the time.
Okay, so now you're taking half a pill in the morning and half a pill in the evening?
Yes.
The healthcare provider should keep in mind that some medications, such as sustained-release tablets, should not be cut.
Now, do you have any feelings about any of these being very beneficial for you? Do you know what they are supposed to be doing?
I know that they are controlling my hypertension and my angina. They are both intended for that purpose. My blood pressure is stable, and my angina is stable, and I'm feeling good.
And what has your blood pressure been running? Do you know
My
the
blood
range?
pressure, yes. It averages now about 140 to 150 over 70, 80.
Okay.
At times I've come into the doctor's office and it was 90, and he'd say, "Why?" And I'd say, "Because you're holding my hand."
Very
And
good.
he knows that.
Have you ever had any allergic reactions to your medications?
I think the only one, and that's the one we discussed, was the patch. And that was why the doctor recommended the oral nitro, because of the skin reaction.
The next medications are your over-the-counter medications, or things that you bought on your own.
Yes.
And the first one is what?
All right, calcium. I found out that calcium carbonate was effective, and it's giving me as much calcium as I need without taking other minerals that are included in the calcium.
Okay. Do you take that with food?
Yes, I take it with my breakfast.
All right, very good.
And then the other,
the next one is?
High potency vitamin.
How many?
I
of
take
the-
one a day.
One a day. That's good, because some people will overdo it. You know, they have that philosophy, if one's good, two is better. And they can end up taking megadoses of vitamins, which is not necessary and can be harmful.
And then I take Metamucil.
And you take that in the
I take a
evening?
tablespoon of that at bedtime.
Okay.
And it gives me a good elimination in the morning.
Do you take any social drugs? Things like alcohol, tobacco, and some people even consider caffeine as a drug. Do you drink alcohol?
No, except some wine occasionally with my dinner.
Okay.
But I limit it to a very small amount, and then I lace it up with soda water. Makes
So
the
you have
same.
kind of a spritzer.
Yes, that's right.
Good. Okay. Do you smoke any cigarettes or?
No.
Okay, that's very good. Never have smoked?
Yes, I did smoke. I quit smoking about 15 or 20 years ago.
Oh, that's wonderful.
I had
That's
smoked.
great. That's good. And do you drink a lot of caffeinated beverages?
Well, I have coffee 2 to 3 times a day. Sometimes it's at home it's decaffeinated.
Oh, okay.
Out, it's not always possible.
Illicit drugs, such as cocaine and marijuana, may also need to be discussed.
I have a few additional questions to ask you. Your medications here don't need any special storage, but where do you store them?
I keep all these in the kitchen drawer. They're lined up in the kitchen drawer. But in the morning, I take out this little box and I put my dosage for the whole day in this little box.
So this is kind of a memory aid for you.
That's
for
right.
taking your pills, a reminder. And you put all your pills for the day in there,
That's what I do.
and when the day is over, the pills are gone.
Pills are gone.
Okay. Another question I'd like to ask you is, do you ever share any medications with anyone?
No, I have never shared any medication with anyone.
Good. Because that can be a problem. People think that if it works well for them, it'll work well for their friend. And sometimes that's not always the case.
That's right.
How about home remedies? Do you use any home remedies?
No,
Nothing
like
that
I
you
say,
make at home and
no, I don't.
to rub on your skin or drink? Or...
No.
Okay, fine. Now, do you have any problems getting your medications, like transportation to and from the pharmacy?
No.
Okay. Now, I know you're taking a lot of medication, so I need to ask you, do you have any financial problems in buying these, or is it difficult for you to afford them?
They're very expensive to buy, and I'm on Social Security. I supplement myself by belonging to ARP.
What would you say you pay out of the pocket per month for these medicines?
I'd say it was over $100 a month.
Some people, because their medications are so expensive, will omit doses to try to stretch out their prescription, will skip doses and not take it at all, because after all, when it comes to whether they buy food or medication, the food usually wins out.
It is true, and I admit that sometimes I'm guilty of skipping a day on the Mevacor and only taking one, because I think I'm putting myself ahead, although I realize I'm not.
Yes, the Mevacor is very expensive.
Mevacor is the most expensive.
Yes. Now, the other and the last medication I want to talk about is the Xanax. Why do you take Xanax?
I take just a half a tablet at bedtime, just for a comfortable sleep, and then I can fall asleep immediately.
And is that every night?
Yes.
Do you have any drowsiness during the day?
No.
Because of that?
No, not at all.
You know, you have to be very careful if you do take any alcohol with the Xanax, because one can potentiate the other.
Yes.
Well, that's the end of the medication history. I'm very pleased, Mrs. Eidenberg, that you know so much about your medications and that you're aware of side effects, beneficial effects, and that you will be asking your healthcare provider to give you more information when you return.
The preceding medication history was conducted under ideal conditions, at a table, in a room with adequate lighting, and without distractions, to facilitate the patient's review of the meds and to aid the clinician's documentation of the drug regimen. Of course, as we in home care are aware, such ideal conditions are rare. In fact, they may only exist in videos. If the patient is bedbound or otherwise unable to self-administer medications, identify who the primary caregiver is and conduct the interview with that individual. Let's take another look at the interview process as our home health nurse and physical therapist take their medication histories.
I will also need to list all your medications for the purposes of records in our office. Let's see if you can open this medication right here, and if you can read that for me.
The clinician should note if the meds are in their original containers and have the patient open them to observe dexterity, functional ability.
Do you have any allergies to medications?
Yes, codeine and vitamin B12 shots.
The clinician should confirm the patient's known allergies with those identified on the pre-interview documentation. Every effort must be made to ensure the information is accurate. Documenting the source of the information from the original medication containers is an appropriate way to ascertain information. The label on a bottle of prescription medication constitutes the pharmacist's transcription or documentation of the orders. Such medications are noted in the clinical record and on the 485. This is consistent with acceptable standards of practice.
Do you know what this is for?
That's a Neurontin.
Mm-hmm.
It's for diabetic neuropathy.
Okay.
Having the patient or family verbally describe in their own terms the intended action, side effects, duration, dosage, and frequency allows the clinician to determine the patient's or family's use and understanding of the medication.
Okay, let's get this straight. Now, I'm reading them, but I want to see you tell me what it says on the label.
Oh, this is Diovan.
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 Okay.
And that's for my arthritis.
Having the patient read the medication labels and repeat back the instructions also provides a way to ascertain the patient's functional status and comprehension, and will help to score OASIS items such as MU 390 vision and MU 780 management of oral medications, MU 790 management of inhalant mist medications, and MU 800 management of injectable medications, MU 810 patient management of equipment, and MU 820 caregiver management of equipment. An inability to read instructions or medication labels is a significant impairment in function and must be addressed by ensuring the labels are written in large, bold type. Labels can be made available in Braille for the blind. Reading and literacy ability can also be assessed and will have an impact on teaching methods. A referral to occupational therapy for additional functional assessment and intervention may be indicated if the review of the patient's functional status related to medication management indicates deficit areas.
Just need to make sure you haven't mixed up any drugs in here. They're all the same thing.
Some drugs must be taken whole and not cut or crushed or broken, and may need an alternate route of administration. Assessing the side effects the patient notices may point out food or drug interactions and patient compliance. Rescheduling of the times when meds are taken or changes in how meds are administered may alleviate symptoms. Finding out what a person does when he or she notices a side effect is important. Education about what to do with side effects or missed doses can be provided by the clinician according to state practice guidelines or agency policy. Drugs and treatments ordered by the physician and not documented on the 485 plan of care should be included in the clinical records, including over-the-counter drugs. If the clinician determines the patient is taking medications not ordered by the physician, or is experiencing any problems with any medications, or identifies potential adverse effects and/or reactions, the physician must be alerted. Patients' allergies to medications must also be verified and documented on the clinical record. Identifying the social drugs in a non-judgmental way may prompt patients to admit their use. They may not consider them social drugs unless the clinician specifically asks about each type of product.
Do you smoke?
No, I never smoked.
And based on that, what about recreational drugs? Do you take marijuana?
Oh.
Okay. We have to ask, believe it or not. And I assume if no marijuana, no cocaine or anything
Right,
else.
no.
Okay.
And not until now, anyway.
Also ask about products with high alcohol contents, such as cough syrups and certain mouthwashes, as they may interfere with medications. Use of such products at different times may alleviate their effects. Seeing the actual medication area can be an asset to the clinician in assessing patient compliance and whether or not the patient is stockpiling outdated medications. Education on proper disposal of outdated medications can be done at this time. The Federal Department of Environmental Protection is now recommending that medications be disposed of by rendering them useless by crushing or other methods and disposing of them in the trash in a secure container so children and pets do not have access. Flushing down the toilet is no longer recommended, as drugs are getting into the nation's water supplies in increasing amounts. Always be sure to follow state and local community disposal requirements and agency policies.
Ms. Bryson, do you share your medications to any of your friends or neighbors?
No.
The discussion about shared medications may also elicit other family members' needs and/or difficulties with finances, warranting a social work referral as well. The use of herbal remedies and over-the-counter medications is increasing. Because they are advertised as herbal or natural or are over-the-counter or OTC and are less costly than many prescription medications, patients are using them in increasing numbers. The most common OTC drugs to be used have been found to be aspirin, laxatives, and vitamins. Many of these OTC products have the potential to cause serious toxic effects and major drug-to-drug interactions, interfering with treatment regimens and possibly doing more harm than good. For example, aspirin taken with a prescribed anticoagulant can cause bleeding. Patients should be cautioned to speak with their physician before taking any OTC medication on their own. Clinicians cannot advise patients to take an OTC without physician approval. Clinicians must inquire about the use of these products and understand and educate about their potential interactions. Patients may not consider them medications when asked about their meds, or may be reluctant to share their use of such items with the clinician. Again, asking in a non-judgmental way about such products may assist in gaining the patient's trust and confidence in reporting their use. Some examples of herbal remedies and their effects include kava and chamomile. Used to calm nerves and decrease anxiety, they may cause sedative effects and can increase the risk of bleeding with anticoagulant therapy or other OTC pain relievers. Echinacea, used as a cold remedy but may cause liver toxicity and alter the effects of immunosuppressants, treatments for arthritis, antifungal preparations. It's also not recommended for MS patients, those with blood disorders, collagen, autoimmune disorders, or HIV/AIDS or TB. Garlic is used to improve the cardiovascular system, but it can impede drugs used to decrease stomach acid and can lower blood sugars. It may counteract the effects of high blood pressure drugs and should not be combined with anticoagulants. Ginkgo is used as a natural blood thinner and can interact with anticoagulants and aspirin or other pain relievers to increase bleeding. Ginseng is used to increase the sense of well-being. It may increase bleeding risk with anticoagulant therapy, interfere with digoxin and antihypertensive drugs, and block the effect of morphine for those needing it for pain control. St. John's wort is used for depression. It can decrease the chemotherapeutic effects in patients with cancer and on chemo, as well as decrease the therapeutic effect of AIDS drugs or drugs used to treat those with transplanted organs by reducing the prescribed drug's efficacy. Medical social workers can assist patients in an evaluation of financial resources and assist them in obtaining discounted drug programs to aid in compliance with medical treatment regimens. Also, if your patient is price shopping at different pharmacies or using different prescribers, a need for a social work referral for financial assistance may be indicated. If the clinician finds discrepancies in the physician-ordered medications, including duplicate drug therapy, such as a drug prescribed in both generic and trade name form, clarification with the patient's primary physician would be required. If different physicians are involved, coordination of the plan of care with each must be considered as well. If the discrepancy was identified by a therapist, clarification with the patient's physician should be done according to state practice standards and agency policy, as this may vary. One way to address this issue is to refer back to the agency nursing supervisor, who would contact the patient's physician for clarification of the correct drug regimen and possible referral for skilled nursing visits for skilled assessment and teaching and training activities about the medication regimen. While review of the drug regimen is consistent with the scope of practice of the rehab therapists, assessment and teaching about the medications are part of the scope of practice of the registered professional nurse. It is recommended that therapists consult state regulations and practice acts to identify possible practice restrictions related to drug review activities and medication issues.
Ms. Bryson, I'm going to leave you this brochure.
By the end of the interview, the clinician has confirmed the patient's and/or family's understanding of the medication regimen. By the end of the visit, the clinician should identify and document that the patient and/or family or caregiver were able to relate the amount and frequency of all the medications, able to say when to take the medications from the medication bottle or box, agreeable that they are comfortable with all aspects of the medication administration, agreeable that they will refer all medication questions to their physician, or were unable to accept any responsibility for the medications. If unable, then the physician must also be alerted according to state practice guidelines and agency policies. Documentation should include a list of all medications, herbal remedies, and over-the-counter drugs identified from the medication history, including the medication name as indicated on the prescription bottle, the date of the prescription, the dosage, frequency, route of administration, pharmacy name and phone number, and ordering physician. The clinician should also document any necessary interdisciplinary referrals. Always give written instructions to reinforce any education provided to the patient or family. Document what was provided according to state practice guidelines and agency policies.
When providing medications for the elderly patient, there are special considerations to keep in mind. There are 4 areas in which physiological changes that occur with age can affect the half-life of medications: absorption, distribution, metabolism, and excretion.
The first is absorption, which determines how much drug enters the bloodstream from, say, an oral tablet or a capsule. Some of the changes that occur in the elderly are a decrease in the gastrointestinal motility. They have a decrease in the acidity that's in the stomach and the GI tract. There's also a possibility that it may have lower numbers of the absorbing cells in the intestines. Distribution determines how much drug reaches the site of action from where it's absorbed. There's a shift in the percentage of fat to lean body mass in an older person, which will essentially give lipid-soluble drugs a larger volume of distribution. And since they're distributing into a larger space, it will take a longer time to be eliminated from the body. Most of the drugs that are active in the central nervous system all need to be lipid-soluble in order to be absorbed into the central nervous system. So these are the drugs that will be hanging around a little bit longer, having their effect for a much longer time, and possibly accumulating in an elderly person. The next point is the elimination of the drugs from the body. And elimination is accomplished by 2 means. They're either metabolized in the liver or they're excreted entirely through the kidneys. There are certain metabolic functions that occur in the liver which change with age, and there are some that don't change with age.
It explains why some medications last the same amount of time in young people as they do in older people, while other medications have much longer half-lives in the elderly.
Excretion of the drugs from the kidneys is possibly affected by age, primarily because renal function decreases with age. There are decreases in the numbers of functioning cells in the kidney themselves, and also the amount of blood going to the kidneys is also decreased with age.
The physiological changes that Irene has described explain why older people have so much more problem with medication. And in fact, problems with medication are very common in older people. One of the reasons that this happens is because of polypharmacy. And polypharmacy means the use of many medications at the same time. And we know that older people do that. If an older person has a lot of medical problems, they may need to use a lot of medications. You also described for us earlier your interview with a woman who was taking 11 medications. Out of the 11, if 7 were essential, this is a particularly problematic person to prescribe medications in, because you certainly want to avoid any medication that is not essential. Which ones aren't essential? Well, you described that she was taking Xanax every night, a sleeping pill. As Irene described, this medication is likely to have a prolonged half-life. Her brain is likely to be particularly sensitive to it. You have to wonder if that really makes sense in somebody already on so many medications. If the medication is not really needed, the best advice I can give anyone is don't use it in the first place.
3 months ago, I had a virus in my inner ear, which caused me to be very dizzy, lose my balance, and feel sick in general. The doctor prescribed Transderm Scope. This drug made me very nervous. It affected my bowel movement and urination, and I felt very bad in general. I stopped taking this after 4 days. Did not call the doctor, and I just stopped taking it on my own. Right now, I feel very good.
She had the exact side effects that you were talking about. She wasn't able to urinate. She got very constipated. And I believe these are the anticholinergic.
That's right. These medications can also cause orthostatic hypotension, that is lightheadedness when people stand up, blurred vision, dried mouth, and in fact confusion. Confusion is particularly a problem in people who have dementia. Older people are more sensitive to anticholinergic properties in all organ systems, or at least in most organ systems. And this relates to what I call drug-disease interactions. And that is, the medication used to dry up the nose when somebody has a cold also goes to the bowel, also goes to the bladder, also goes to the eyes. And so it will have effects on many organ systems other than the ones that you would like them to have an effect on.
The average elderly person is unaware or they do not read the labels on the over-the-counter cold medications that said you shouldn't take this if you have glaucoma or urinary retention or anything like that. And I think this is one of the things where nurses can help to educate.
But doctors frequently don't do that as well. If you call your doctor and say, I have a cold, your doctor may prescribe a cold medication without really carefully looking at the other problems that you have. And that often falls to the nurse to carefully check the medication against other problems, and the nurse can consult with the pharmacist.
As long as I reached 80, I said, I don't worry too much about the medicine. And I cut it down if I don't feel like I should take it. And then again, when I need it, I take it again. And of course, it mixes the doctor up, you know. He says, when did I tell you to do that? I says, I don't know.
One thing that you might find, or the nurses might find in the community, is that a patient will very often tell a nurse or a pharmacist something about the medications that they're taking without telling their doctor, just because they feel that they would be disappointing the physician if the doctor found out that they weren't taking it exactly the way that he prescribed. So they will often confess sort of on the side that I really don't take my medications this way. I know I should, but it's just difficult for me to remember to take them. It's important to include the patient as a part of the team in determining what medications they're going to be taking, and how they're going to be taking them. It needs to be able to fit into their lifestyle.
Right. And often another medication can be chosen. If we know that the patient won't or can't take their medication 4 times a day, we can choose a different one that can be given once a day. I think a great example of that is some of the transdermal patches that have been developed, particularly useful for older people. I have hypertensive patients who are demented, and they can't remember to take their medications even once a day. And it's very difficult, even though families try to call and remind the person. There are now some antihypertensive medications that can be delivered in a patch, put on the body once a week.
On a similar note, some elderly people have trouble swallowing large pills, so medication in crushable or liquid form may have to be prescribed.
At night when I go to bed, I feel an upset stomach, a sort of a little pain, and I attributed that to the Mevacor. So I decided to take it after my lunch period and found 100% more satisfaction. I do not go through that pain at night. I don't know how to account for it, but it works for me, and that's what I'm going to do.
Food-drug interactions, it's very difficult for the patients. A lot of times they don't know when to take their medications with food or when to take them on an empty stomach. And if they're taking more than one, it's hard to know which ones you have to take with foods. Some of the non-steroidal anti-inflammatory drugs or other drugs that are very irritating to the stomach need to be taken with food, and food can help them prevent the irritation and possible ulceration that may occur.
And as you said, food interactions with drugs, foods that block the absorption of a medication or more serious ones that can really affect the effectiveness of a medicine.
The drug Fosamax for prevention and treatment of osteoporosis is a case in point. It must be taken after rising in the morning on an empty stomach with a full 8 ounces of water. The patient may not lie down nor eat nor take any other medication for at least half an hour after taking this medication. These tablets may not be crushed, sucked, or chewed and must be swallowed whole. Before lying down after the 30 minutes, the patient must eat something. This is due to the potential for severe stomach-related side effects if these precautions are not followed.
Often older people, when they're having toxicity from drugs, simply decline in very vague ways. We often call this failure to thrive. It may be that a person doesn't eat as well, loses some strength, becomes a little sleepier, becomes depressed and withdrawn. All of these can be toxic side effects from medication and not just confusion. So that whenever somebody seems different, always suspect the medication.
What is your birthday?
December 2nd, 1912.
And if I said 100, take away 7, what's the answer?
93.
Collaboration with the medical social worker is important because medical social workers, or MSWs, are trained to conduct mental status exams and can help in determining patients' abilities and competency. They can be a part of the interdisciplinary team that can assist in the identification of problems and suggest resources in conjunction with nursing, PT, OT, and SLP professionals. MSWs are one discipline that conducts mental status assessments. The OASIS assessment includes items that assess other aspects of cognitive functioning and behavior. Nursing, OT, or SLPs may also handle more details of the patient's cognitive assessment. OASIS items include MOVE 560, cognitive functioning, MOVE 570 when confused, MOVE 580 when anxious, MOVE 590, depressive feelings reported or observed in a patient, MOVE 610, behaviors demonstrated at least once a week, MOVE 620, frequency of behavior problems.
One category of medications that is of growing concern in older people are the antipsychotic medications. The problem exists because there are two separate and distinct uses for this kind of medication. One of its uses is for treating psychotic people who have schizophrenia or paraphrenia. And these drugs have been shown to be highly effective for treating these very serious disorders. On the one hand, they've never been shown to be very effective in treating these disorders. And on the other hand, they are very toxic. In the future, doctors and nurses will have to very carefully document the target behavior that they are trying to treat, the reasons that they have chosen to use antipsychotic medications, and their ongoing monitoring processes for making sure that patients don't become toxic from these medications.
Mark and Irene, I've found many of our patients have difficulty with eyesight, some dexterity problems, and are finding it hard to open their bottles, see their medications, read the labels on the medications.
I think that the packaging of medications is extremely important. We know that compliance is a serious problem with medication use. And one of the compounding problems is the way medications are put into bottles. I tell my patients to talk with their pharmacist and tell them that they want a non-child-proof cap, that if they need a wide-mouthed bottle, they should get it. If they need a label that is written in larger print, that has additional information, such as what the medication is for, they should demand it.
Mrs. Herman, would you open that for me? I want to make sure you can take them easily. No problem. And do the same thing with
Sure,
that.
clicks.
Good.
Which is so much easier than that other type with the child preventive top. I can't open those at all. So when I go to the drugstore to get the prescription, I make them change the top while I walk.
The selection of appropriate medication compliance aids based on patient need, abilities, deficits is an appropriate discussion during the drug regimen review. OTs can assist patients in choosing appropriate med aids when ADLs may be problematic or dexterity issues may be a factor. Safety concerns should also be reviewed with the patient. If a patient has grandchildren, emphasis on keeping the medications out of the reach of small children would be appropriate.
On the same line, many elderly don't take or comply as we would like them to with their medications because of cost. And I think healthcare providers really have to take this into consideration, and oftentimes they'll extend their medications to last longer, omit doses and things like that.
I think one thing that you have to note also is that the price of medication, the healthcare provider may not always realize that the price is an issue. The patient may just not fill the prescription, just leave it, and once they find out how much it's going to cost, to say, well, I've gotten by this long without it, maybe I can get by a little bit longer. The cost is prohibitive for me to use this, and it comes to effect these days with some of the new oral antibiotics that are being taken that are very expensive.
And so it becomes important when you're prescribing a medication to a person to ask them, is it better to take the medication 4 times a day and the medication will be less expensive, or would you like to pay more to have a more convenient medication that you might be able to take once a day?
In home care, social workers can assist clinicians and patients to identify resources to assist in obtaining needed medications. The Medicare Modernization Act, begun in May 2004, provides for the voluntary Medicare prescription drug discount card program to give immediate relief to people with Medicare to help reduce their costs of prescription drugs. However, the program is complex, and patients may need assistance in understanding this benefit and help in enrolling. Full details can be found at the Medicare website at www.medicare.gov or by calling Medicare at 1-800-MEDICARE.
Besides cost, the other factors that seem to affect whether or not people fill their prescription are things like whether or not it's for a chronic condition or an acute condition, whether or not the patient understands what the medication is being used for, whether or not they believe that the medication will be effective, whether or not they believe the medication will cause them side effects, and how much faith they have in their doctor.
Problems with self-administration of multiple medications in older persons have been shown to include omission of doses, medication errors, taking other people's prescriptions, and incorrect use of OTC drugs. Studies have also shown that when patients receive routine medication instructions along with written fact sheets and a written medication schedule, they make fewer medication errors than those who only receive the instructions. The home care clinicians have a unique opportunity to provide appropriate medication instruction and supervision to both the patient and the family. Pictures and symbols can be used to facilitate compliance and understanding of the medication regimen with all types of patients. With instruction, family members can be the ones to provide reinforcement of the medication regimen by reviewing the schedule with the patient on routine intervals. For clinicians conducting the drug regimen review, documentation of the drug regimen must include documenting the medications, both prescribed, OTC, and herbal remedies. It must include the date, medication name, dose, route, frequency, the pharmacy dispensing the drug, and the ordering physician. In addition, the clinician should identify that the client and/or caregiver, family, were able to relate the amount and frequency of all medications, able to say when to take the medications from the medication bottle or box, agreeable that all are comfortable with the aspects of the medication administration, agreeable that they will refer all medication questions to their physician, or were unable to accept any responsibility for the medications. In the event that they were unable to accept responsibility for the medications, a notification to the physician should be initiated according to state practice standards and agency policies. Referral for skilled nursing intervention may be appropriate. The drug regimen review is one tool in the comprehensive assessment that clinicians can use to assess patients' compliance with their plan of care and to educate patients and families on their medication regimen. Appropriate intervention then depends upon the clinician's scope of practice and competency, agency policy, and the patient's needs. Appropriate assessment, referrals, documentation, and follow-up by the clinician will facilitate the best possible outcomes for the patient.
Well, thank you, Miss Bryson. It's been a pleasure meeting you.
And you too.